Imagine going to the doctor with like a vague ache or maybe a noticeable lump on your leg.
Right, something that seems totally harmless.
Yeah, exactly. But then you spend the next 245 days just bouncing between specialists, dealing with misdiagnoses and just, well, total administrative purgatory.
All while a highly aggressive rare cancer is just quietly growing in your body.
It's terrifying. I mean, we usually think the biggest hurdle to surviving a rare disease is the underlying biology, right?
Naturally.
But today we are looking at this massive global data set that proves the real threat might not be biological at all. It's bureaucracy.
It really is. It's a profound shift in how we understand medical timelines.
Welcome to today's deep dive, by the way. I'm so glad you're joining us for this.
Yeah, we are looking at a 2026 global cross-sectional survey. It was just published in the journal Cancers.
And this was conducted by the Sarcoma Patient Advocacy Global Network, right? Or SPAGN.
Exactly, SPAGN. And what's wild is they didn't just pull a few regional hospital files. They gathered incredibly granular data.
How much data are we talking?
We're talking 1,803 patients and their caregivers across 19 different languages.
Oh, wow. That is a completely unprecedented global snapshot for this specific field.
It really is.
So our mission today is to look at the hidden systemic hurdles in global healthcare that this data exposes. We are investigating exactly what causes these agonizingly long waits for a diagnosis.
Right, looking past just the cells under the microscope.
Okay, let's unpack this because, given that our audience knows we're dealing with sarcomas,
Yeah.
and like everyone is pretty familiar with the fact that there are over 100 distinct histological subtypes of these soft tissue and bone cancers.
Highly heterogeneous.
Right. So the immediate assumption when reading this SPAGN data is that the sheer biological complexity is what causes the delays.
Sure, you'd think so.
But that's where this data takes a hard left turn, isn't it?
It completely pivots. I mean, the biology is complex, yes.
Yeah.
You have tumors arising in deep muscle tissue, fat, blood vessels, bone.
Right.
And because of that biological diversity, they often present with an incredibly hard-to-suspect symptom profile.
Like what? Just like random aches.
Yeah, exactly. A painless lump. Or maybe a vague abdominal fullness.
Stuff you'd easily brush off.
Exactly. But to understand why the medical system is failing these patients, we have to isolate exactly where the delays in the timeline are occurring.
So how did the study actually map that out?
Well, this SPAGN study measures what they call the total diagnostic interval.
Right, which is the entire trajectory. From the very first day you notice a symptom all the way to the day you receive a confirmed definitive sarcoma diagnosis from a pathologist.
Precisely. And in this global cohort, the median total diagnostic interval was 92 days.
Wow. That is 3 full months just to reach a baseline diagnosis.
Yeah, just to figure out what it is.
Yeah.
But the interquartile range,
Meaning like the middle 50% of patients.
right, the middle chunk of the data, that stretched up to 245 days.
That's nearly 8 months.
And the absolute maximums in the data stretched into years.
That is just unacceptable. So how do we figure out who's at fault here?
Well, the critical mechanism the researchers used was splitting that total interval into 2 distinct phases.
Ah, okay. The patient interval and the specialist interval.
You got it. The patient interval is the time from that first symptom to the very first time the patient consults any healthcare professional.
Right.
And the specialist interval is the time from that first clinic visit to the actual definitive diagnosis.
Okay, so I'm looking at the numbers for that patient interval right now, and the median time it takes for a person to actually go to the doctor is 30 days.
Yes, 30 days.
Honestly, waiting a month to see a physician about a weird bump or like a vague, non-debilitating ache, that doesn't sound uniquely terrible.
Not at all.
I mean, people have jobs, childcare, life. Getting a non-emergency appointment takes time. We always hear this narrative in medicine that patients delay their own care, but
Yep.
Is the patient really the bottleneck here?
The data completely absolves the patient. Totally. As you said, waiting 30 days to have a seemingly harmless lump checked out is completely standard behavior, especially for symptoms that don't immediately disrupt your daily functioning.
Right, if you can still walk to the train, you're probably not rushing to the ER.
Exactly. The patients are seeking help in a clinically reasonable time frame. It's what happens after they enter the clinic doors that reveals the real crisis.
Because if the total median wait is 92 days and the patient took 30 days to go in...
The remaining 62 days are spent navigating the medical system.
Oh, man.
And remember, that 62 days is just the median. For many, it stretches into 6 or 8 months.
Just stuck.
Yeah. What's fascinating here is that the delay isn't some biological mystery being slowly unraveled in a lab.
Hmm.
It's a structural failure.
So the system itself is taking over 2 months just to figure out what it's looking at.
Yes, often just bouncing the patient between primary care, urology specialists, and imaging centers.
2 months of being a patient who knows something is wrong, who is actively asked for help, and is just stuck in diagnostic purgatory.
Yep.
Let's look at the mechanics of that 62-day specialist interval. Because if the delay is happening inside the system, the logical assumption is that certain types of sarcomas,
Right, the tricky ones.
yeah, maybe the really aggressive ones or the ones hidden deep in the viscera, you'd think they must be taking longer to identify because they were physically harder to biopsy.
Or biologically trickier to stain in pathology. It seems like a bulletproof assumption.
It makes sense.
A deep retroperitoneal tumor should logically take longer to diagnose than a superficial lesion on your forearm.
Right. But what does the data say?
The survey reveals that tumor characteristics, like this specific sarcoma subtype, the patient's age at onset, or whether the disease was localized or already advanced,
Yeah.
they were not independently associated with the time to diagnosis.
Wait, really? So the sheer complexity of the disease, like the 100+ subtypes, didn't actually dictate how long it took the system to diagnose it?
Not independently, no. I mean, there was a slight, statistically non-significant trend showing that lower limb tumors took a bit longer
Why lower limbs?
because they are heavily misclassified as sports injuries.
Oh, wow. Pulled hamstrings and stuff?
Exactly. But overall, the tumor's biology was not the driving factor behind the timeline. The delays are driven almost entirely by patient-reported structural barriers.
Okay, let's get into those barriers because the numbers here are staggering. 38.8% of patients reported experiencing a misdiagnosis,
Almost 40%.
and 33.8% reported a lack of provider awareness. Like, the doctor literally didn't have a rare connective tissue cancer on their radar.
Which is terrifying.
Yeah, and 26.6% cited long waiting times just to get basic scans or specialist appointments.
To understand the gravity of that, we have to look at the clinical mechanics of a misdiagnosis.
Well, walk me through it.
Well, because sarcomas often grow deep within muscle tissue without immediately pressing on a nerve, an initial ultrasound might just show a dense mass.
Okay.
So a general practitioner reading that scan will play the statistical odds. They will look at the patient, look at the ultrasound, and diagnose a benign lipoma or a hematoma from a gym injury.
Because that's what it usually is.
Right. The biological quietness of the tumor weaponizes the doctor's standard diagnostic playbook against the patient.
So having a rare cancer isn't just a biological fight, it's a administrative one.
Highly administrative.
It's like being stuck in a life or death customer service phone tree. You know, press 1 for orthopedics, press 2 for physical therapy, press 3 for a benign cyst.
That's exactly what it feels like.
But no one knows which department you actually belong to because the rare oncology menu option is totally hidden from the primary care doctor's screen.
And every time you are routed to the wrong department, there is a quantifiable penalty.
A penalty, like in time.
Yes. The data show that every single barrier a patient encountered increased their time to diagnosis by 31.5%.
Wait, so a nearly 32% time penalty for every wrong turn in the system.
It is a compounding penalty. And that penalty isn't just measured in days, it's measured in prognosis.
Oh, because the cancer is growing.
Right. Let's trace the pathway of that 38.8% misdiagnosis rate. When a sarcoma is chalked up to a, quote, lifestyle-related cause, the patient is sent down the wrong treatment pathway.
Right.
They might spend 6 weeks doing physical therapy for a tumor, which just masks the progression of the disease.
That's awful.
Worse, they might undergo an inappropriate, unplanned excision by a general surgeon who thinks they are simply removing a benign cyst.
Which is incredibly dangerous, right?
It is catastrophic.
Yeah.
Cutting into a malignancy without the proper wide margins or oncological protocols can spread the cancer cells into surrounding healthy tissue.
Oh, geez.
Yeah, which severely complicates future curative surgeries and drastically increases the risk of local recurrence.
Yeah.
Misdiagnosis doesn't just cost time. It actively alters the biological landscape of the disease.
So you're doing exactly what society tells you to do. You go to the doctor, you follow their advice, you diligently do your physical therapy.
Yeah.
And all the while, the clinical heuristics of the medical system are failing you.
Entirely failing you.
Which brings us to the next layer of this data. Because if the system's reliance on standard assumptions is driving these delays, does the system apply those assumptions equally to everyone who walks into the clinic?
The diagnostic pathways show distinct, measurable disparities. The system absolutely does not treat everyone in that waiting room equally.
Here's where it gets really interesting. When the researchers broke down the diagnostic timeline by demographics, they found a massive gender gap.
A huge gap.
Men had a 40.9% shorter time to diagnosis than women, a nearly 41% advantage.
That's a striking number.
But the crucial detail here, the piece that completely removed the patient's behavior from the equation, is that both men and women had the exact same patient interval.
Yes, the median time from symptom onset to first medical consultation was 30 days for men and 30 days for women.
So women are not waiting longer to seek help.
No.
They aren't internalizing their symptoms or delaying appointments more than men. They're showing up at the exact same time with the exact same symptom profile.
Exactly the same.
So why does the system take a median of 60 days to diagnose women, but only 35 days to diagnose men? Is this a data anomaly or evidence of systemic bias?
Well, this specific survey is observational and cannot definitively map the psychological mechanism occurring in the physician's mind.
Sure.
The structural data points us to a clear conclusion. Because the delay is not happening before the clinic visit, it points heavily toward differences in clinical decision-making, triage severity, or referral pathways once the patient is physically in the exam room.
Meaning a general practitioner hears the exact same symptom description from a man and a woman and initiates a completely different clinical workflow.
If we connect this to the bigger picture, this disparity aligns with decades of broader medical sociology research.
Regarding how symptoms are perceived.
Exactly, particularly pain, fatigue, or vague somatic discomfort. Research shows how those are perceived and prioritized by healthcare providers based on gender.
Right.
Women's symptoms are statistically more likely to be attributed to stress, anxiety, or psychogenic causes rather than severe underlying organic pathology.
So if you are listening to this right now and you've ever had a legitimate physical pain dismissed by a provider who told you to just reduce your stress or wait and see.
Yeah.
This data proves that your experience isn't just an isolated anecdote. It is a measurable systemic failure happening on a global scale.
It really is. In the specific context of sarcoma, where the early symptoms already mimic benign everyday ailments, this baseline bias acts as an accelerant for delays.
How so?
Well, if a man presents with an aching, unexplained mass, the physician's clinical heuristic may trigger an immediate MRI or a specialist referral to definitively rule out something serious.
Okay.
If a woman presents with the same mass, the heuristic may default to prescribing an anti-inflammatory and suggesting a follow-up in a month if it doesn't resolve.
And when she comes back in a month, she has accumulated another structural barrier, adding that 31.5% time penalty to her diagnostic timeline.
Exactly. It demonstrates that optimizing diagnostic pathways isn't merely about administrative efficiency. It is fundamentally about equitable care.
That makes total sense.
Diagnostic urgency must be triggered by the objective clinical presentation, not heavily filtered through the demographic profile of the patient.
So we've established that the system's biases severely skew the timeline for women.
Yes.
But what happens when the system's structural biases skew the data itself?
Yeah.
There is another finding in this survey regarding global income levels that is so counterintuitive, it essentially forces us to rethink how we consume medical statistics entirely.
The income paradox. It is a brilliant case study in analytical blind spots.
Okay, so the SPAGN survey analyzed the time to diagnosis across different global economies, and the data showed that patients in low and lower middle income countries were diagnosed 59.4% faster than those in high income countries.
Which sounds amazing at first glance.
Almost 60% faster. But wait, I'm looking at the pathology numbers and the source material, and it just doesn't compute.
No, it really doesn't.
The text explicitly states that pathology services, like the actual laboratories, stains, and experts needed to definitively diagnose a rare cancer, are available in over 95% of high-income countries.
Correct.
But only about 35% of low-income countries.
That is the reality of the global infrastructure, yes.
So how on earth are under-resourced countries operating with a massive deficit in basic pathology infrastructure, diagnosing an incredibly complex disease 59% faster than fully equipped healthcare systems?
It defies logic.
Are doctors in low-income countries just vastly superior diagnosticians who don't need lab confirmation?
No, and thinking that way is a massive trap. What we're seeing here is not a medical miracle. We are seeing the statistical illusion created by survivor bias and selection bias.
Walk me through the mechanics of that illusion. How does a lack of resources create a faster timeline on paper?
Well, this raises an important question about the methodology of data collection itself. You have to ask, who actually gets to take this survey? To be included in the SPAGN dataset, a patient had to eventually receive a definitive, confirmed sarcoma diagnosis.
Yeah.
And they had to be connected enough to a patient advocacy group or a specialist medical center to actually receive the questionnaire.
Right, you can't survey someone who doesn't know they have the disease.
Exactly. Now, in a high-income country with a robust healthcare infrastructure, the net is cast very wide. Even the really difficult, tricky, early-stage cases eventually get caught.
Because they have the resources to keep testing.
Right. A patient might bounce around the primary care system for a year, enduring multiple misdiagnoses, which, as we know, adds massive amounts of time to the overall median wait.
Yeah.
But they survive the administrative process, they get diagnosed, and they enter the data set.
So they're in the data, pulling the average wait time up, making the high-income system look slower.
Exactly.
Right.
But in a lower-income country with severely limited referral pathways and scarce pathology resources, those tricky early-stage routine cases simply never get diagnosed at all.
Oh, wow. They just fall entirely through the cracks.
Yes. The patient may, unfortunately, pass away from an unknown cause or live with an undiagnosed, untreated mass for years because they never make it to the specialist center. They never take the survey.
That is so dark. It's like evaluating global healthcare speed by only looking at the people who made it to a specialized clinic in a low-income country.
Yes.
It's like reviewing a terrible restaurant by only interviewing the people who actually stayed for dessert. You are entirely missing the massive crowd of people who walked out in frustration after the appetizers.
That is the exact mechanism of survivor bias.
So who does make it to the specialized centers in those under-resourced settings?
Likely, only the patients who present with incredibly severe, obvious advanced disease where the diagnosis is glaringly apparent and rapidly escalated.
Right.
Or, conversely, patients with immense personal wealth who can completely bypass the standard public system and immediately purchase top-tier private care and pathology testing.
So the fast diagnosis in the data is a phantom. It's an illusion. It's fast because the only people left to be counted are the ones who were triaged immediately due to massive severity or who had VIP access. The thousands of patients whose diagnoses were delayed simply aren't in the data to be counted at all.
The data accurately reflects the people in the survey, sure. But the survey methodology inherently misses the most vulnerable population in those regions.
Oh, it's wild.
And if a global health policymaker takes that statistic at face value without interrogating the missing data, they might draw incredibly dangerous conclusions.
Like what?
They might look at that 59% faster diagnostic rate and argue that low-income countries don't need additional pathology funding because they appear to be outperforming high-income nations.
Which would be catastrophic for resource allocation. It proves that in medical data analysis, the silence the missing data points, often dictates the reality far more than the numbers printed on the page.
It is a critical lesson in reading medical literature. You always have to ask, who was left out of the room when this data was collected?
So what does this all mean? We've covered a tremendous amount of ground today, analyzing a data set that spans the globe and dissects the very architecture of medical diagnosis.
We really have.
Even if you, the listener, never have to navigate the complexities of sarcoma, and we sincerely hope you don't, this research is a masterclass in modern medical reality.
Absolutely.
It shows us that interacting with healthcare requires fierce, active self-advocacy if you know your own body and you have a symptom that is repeatedly being dismissed as lifestyle-related.
Or if you find yourself stuck in a referral loop between doctors who seem unconcerned.
Exactly. This data proves you aren't crazy.
You are experiencing a documented structural blind spot.
The system genuinely relies on generalized heuristics that fail at the margins. And particularly if you are a woman, the statistical reality is that you may have to fight considerably harder to override those clinical assumptions.
You have to force the system to trigger a specialist referral.
Yeah, you have to be the one to actively guide yourself out of that administrative phone tree.
It is a sobering reality, but understanding the architecture of the problem is the first step to overcoming it. And I want to leave the listener with a final thought to mull over.
Let's hear it.
We've spent this deep dive analyzing how sarcomas have a hard-to-suspect symptom profile and how they physically mimic 100 other benign things.
Right.
But if our modern medical infrastructure is so heavily reliant on typical common symptom presentations to trigger urgent care and specialist referrals,
Oh, I see where you're going with this.
how many other rare, quiet conditions are currently hiding in plain sight?
That is a haunting concept.
How many other complex diseases are entirely masked by the baseline assumption that common symptoms always mean common ailments.
Sarcoma is just the example we have data for today.
Exactly. The diagnostic landscape is incredibly vast, and it forces you to wonder what else the system is failing to see, simply because its standard playbook isn't expecting to see it.
It brings us right back to the core tension of medicine. We all want the comfort of a definitive, immediate answer. But until the system evolves to navigate the murky realities of the human body without relying on biased heuristics or rigid administrative pathways, the best diagnostic tool we have is our own persistence.
I couldn't agree more.
Stay curious, stay vigilant, and never let the system talk you out of a second opinion. Thanks for joining us on this deep dive.